Here we are talking with Dr. Sandra McBride from El Paso Children's Hospital about pediatric sedation. Many of you have worked with her, but for those of you who haven't, Dr. McBride, will you tell us a little bit about yourself, your background, training, and so on?
Yes, I'm originally from El Paso. I went to UTEP and then graduated from TCOM for medical school, and then came here and did my pediatric residency, and then went to UNM for a fellowship in peds emergency medicine, and I'm back.
So we have an exciting topic today, one that's got some controversy, one that definitely can raise the hairs on the back of your neck if it causes trouble, but let's just start with the basics. How do you choose a patient for sedation? I'll just throw that out there generally, and then I'll give you some examples about what are situations that you would need to sedate a pediatric patient.
Yeah, so it definitely depends on the type of procedure you're going to do. Is it something that's painful, non-painful? Is it an extended period of time? Again, you have to also consider the age and developmental capacity of the child at the time of, trying to devise a plan. Essentially, less than 6 years old, they're very difficult to control as far as behavior and movement. I have been surprised. But coming in and looking at the patient and then looking at the extent of the injury and behavior and so forth will guide me as to looking at the avenues. Is it okay just to do an analgesic, or do we want to go straight sedation? And what kind of sedation? Do you want minimal sedation, moderate sedation? And with the idea that even though we intend to do moderate, usually we sometimes go into deep sedation and so forth, especially with little ones because their metabolism is so different. So you kind of have to play with the amount of doses of particular meds. So that kind of will dictate exactly what we need to do. And also trying to achieve, what is it that you're achieving? Is it something where you need the child to be immobile, or are you okay with the child, coaching the child a little bit? For example, lacerations, as opposed to, you want a very comfortable patient, musculoskeletal. You want that muscle to be nice and relaxed. In that case, you want them very immobile and relaxed. So it all depends on the type of procedure, the age, and the capacity of the child to cooperate.
Okay, that's a great overview. So let me throw a few situations at you and just see, how often are you sedating for imaging, a CT or an MRI?
We don't do that often because usually we're very busy, but here and there we will do it. And we've had instances in which we actually do, even for our special children, special being our autistic children that are aggressive and so forth. I've had a couple of those that come in, and so we'll go ahead and try, doing a little bit of Versed, and then just going up the ladder, if you will, depending on how they react to it. Because again, different types of diagnoses will patients just respond differently. So you kind of have to play with it. I try to go with the lowest type of sedation and then move up depending on what we need to do. I like the propofol or Versed, depending on. Versed is nice if you can control it, but again, you have to look at Versed, and I think it's like 70% success with even CTs and MRIs and so forth. I like it though because it's rapid onset, rapid offset. So
I've seen there's like that papoose thing that'll kind of hold kids tight. What age can you use that until comfortably, do you think?
So it really depends, because I've had some kids, that are 2 years old and they're very, very strong, and they'll break out of it. I've had up to, I think the oldest I've used it on was a 10-year-old. So it really does vary on the child. Again, coaching, because we use different mechanisms. Oftentimes when we had child life, we would use child life to coach them, to tell them what the procedure was. Oftentimes it's just the fear of not knowing what's going on, but if you explain to them, they're willing to listen. We also did some music therapy, and that would work. Some people, even just papoosing is comfortable for them, and that's enough for them to just sit still. So again, it varies. But if they're willing to cooperate, you can do it in, like I said, 8-10-year-olds. I've had a 2-year-old that's broken out of it multiple times, required 3 or 4 personnel to hold the child. So it varies on each temperament, I guess.
Yeah, it's always a good consideration, the non-pharmacologic ways to accomplish this.
Right.
Okay, well then let's go to the next step. So you've decided the patient needs sedation. How many people do you need to accomplish this if you're getting together sedation?
So it really does depend from institution to institution. I think here, what we do at El Paso Children's, we, depending on the type of procedure we're doing, definitely need nursing staff. So we're going to need at least one ancillary. So you need a nurse. If you're going to, depending on if you need radiology there, you'll have the radiology depending on the type of procedure that you're doing. And then it depends. If you have a resident with you, then the attending can focus on just, I personally like to just take care of the vitals, physical exam aspect, and allow the resident the autonomy of, after we've discussed it, of course, managing the meds and taking care of that. Because again, we need to recall that, especially in Texas, RNs are not allowed to administer any medication as far as sedatives are concerned. So again, even if you give them the verbal, they're not allowed to do that. So we're the ones that are responsible for it. So usually it's the nurse that can go ahead and record our vital signs. And then the physician, and then the third one would be the resident physician who's going to do the sedation. And again, in between, we can kind of switch off, but minimum of 3, I would say, because we still need to do the procedure, whatever that procedure may entail, be it laceration as opposed to doing, reduction and so forth.
Okay.
So minimum of 3.
Because we're trying to gear these topics sort of to our future practice, maybe as community emergency physicians, where there's not enough people around to do things. And so if you're doing the reduction, or you're doing the lac repair, or you're doing whatever it may be, does that change, or is that still kind of what you're working with?
It definitely changes. And again, it depends on the procedure that you're doing. Laceration, that's a quick one, so it also determines what type of sedation I'm going to use. Like I do prefer ketofol for the small things. For example, if I'm doing, pilonidal abscess, versus, I've had kids with Asperger's or on the autism spectrum. And it's just a simple laceration to the face, but it's near enough to the eye that it's concerning. So on those, I do prefer the propofol. However, if I don't have a second set of hands, because it's rapid onset, rapid offset with continuous infusion, then I will alter that. Instead of doing the propofol or ketofol, depending on, then I'll just go straight to ketamine. That said, I like to have my whole entire setup together, so I have whatever is going to be required, obviously, for your procedure. Then I'll have the cart out. Usually I don't have the cart out when there's 2 people. When I'm by myself, I have the airway cart, the crash cart, just in case. So that's prepared. I have respiratory on hand as well. So we have the respiratory therapist, so that adds 1 more person to the mix. Nursing is in charge of taking care of my vital signs and so forth. And if at all possible, I like to have another tech or nurse alongside them so that they can hand me the meds and the different instruments that I need. Again, that's going to change the type of medications that I will be using. So I do keep that in mind as well. As far as my setup, it doesn't really change my setup when it comes to like the monitoring aspect of it. I keep them on full monitor. I like to keep, my preference is usually ketamine. So everybody gets Zofran prophylactically from the get-go, because I'm not going to deal with that aspiration aspect, because that's the most common side effect that I've seen. So everybody gets that. They're taken care of there. They've already, depending on the size of the body, will determine where I put a towel roll. Capnography is always a must for me, and I always keep them on the nasal cannula. It just makes it easier, because when you have the nasal cannula attached to the capnography, studies have already demonstrated that you'll figure out if the child is getting ready to desat several minutes before you'd actually see it just on a regular pulse ox. That does not change. The only things that would change would be that I would have everything prepared a little more so. So I'd have all my meds drawn up. The ketamine would be drawn up in multiple aliquots. If I determine that it's 10 mLs, then I'll have 5 at bedside with 10 mLs, which is overkill. But again, I don't want to have to be drying and interrupting my procedure if it's necessary to give another dose or two, especially with your younger kids, they require more dosing with that. So you have to keep that in mind as well.
Okay.
And of course, everything is just on hand. So, and I always have, with those airway, I'm a little more precautious because there's only one of me. So my airway is already drawn. I have the airway tray out. I know the sizing and so forth, just in case.
That's great. There were so many pearls there. Just let me recap. So for when you're doing the procedure, you're getting the airway cart in the room. You're bringing more meds out. In other words, you're making aliquots of more meds. You are giving longer acting agents. And just in general, you're thinking ahead more. And you called it overkill, but I totally feel like it's justified because you're, like you said, you're just you.
Yeah, you just want to have A, B, and C ready just in case, always planning for the worst. And it's great when you just put it away and you didn't require it.
Yeah, totally. So, cool.
Yeah.
Cool. All right. Well, I think you kind of answered one of my upcoming questions, which is monitoring. You said that you routinely use oxygen. You use capnography. Walk us through a little bit more about your monitoring setup, what you prefer.
So with the monitoring setup, I usually have just full monitor being, first, obviously the oxygen's ready to go. And I usually have them, on the high flow oxygen, just in case. Okay. The capnography I have going, and usually I'll have that on the opposite side of wherever it is that I'm going to be doing the procedure, just so that I have everything together. Same thing with the monitor. They're on full monitor, meaning that they also have cardiac monitor on board. Every 3 minutes, the blood pressures are getting checked. And what is it? Oh, gosh, no, I can't even think. The pulse, I can hear it. What is that called? Like, I have it on audio, so that I don't have to keep looking up. So the heart rate, I can hear the heart rate. So if it's going up or down, I already include into that.
Thank
you.
Yes. Okay.
Yes. There you go.
That's a good trick. Yeah.
Cool. Yeah. So I don't have to constantly be looking up and down. So that's very helpful. Again, I think that's very important as well, especially when you're operating on your own, is making sure that you set up that room appropriately, being, having everything on the opposite side so that it's easy to just look up. So
nice. Like it.
Yeah.
Cool. Okay, let's get into the next topic, and that's NPO status. How long do pediatric patients need to be NPO before they can have sedation?
So that's very controversial. I've seen the new literature. The latest literature says if it's an emergency, you can just go ahead and go through with it. But we don't have true documentation and literature out in pediatrics. I don't know about the adult side, but as far as the pediatric aspect, we don't have literature to support this. However, previous literature states, the typical. So it's 2 hours for clears, and you'll go with the 4 hours for formula. For regular milk and solids, it's 6. And so depending on the urgency of the situation, if it's something that needs to be done right away, obviously, but you bypass it. It's an emergency department. Now, if you have the time to wait, I usually am I want to say I hold off, and I'm a little more conservative, and I will wait. I usually, if they have sips of water before, for me, I have not had any issues, luckily, with any kind of aspiration. Again, the 6 hour mark, usually I'll wait max of 4 hours for solids if it's something that's necessary, needs to be done, especially during our respiratory season. And I might get, docked by some others. But again, with the new literature that's coming out, I don't see any reason to have to delay the procedure if it's unnecessary. And again, I haven't had any bad results thus far. Okay. So I'll knock it by 2 hours usually. And so far, crossing my feet, everything's been great.
Let's talk about atropine. Is this something that you give patients who are being sedated, or is that more just an intubation thing?
It's more of an intubation thing. And even to touch on that, so let me go back. You have a hypervasovagal situation that you tend to see in less than a year old, but predominantly less than 6 months. So whenever we're doing, especially RSI, that's when
Mm-hmm.
we take the atropine, because they'll brady out. And so they'll have bradycardia and so forth, because they just have that, for some reason, that hyperreaction or sensitivity. And so they end up bradycardic and so forth. However, you have to keep in mind also that with the atropine, once you've administered it, you don't have that ability for the bradycardia to respond to the hypoxia or hypoxemia, because whenever these kids do become apneic, they're not going to become bradycardic if you're giving atropine. But based on what I've seen, if you have your choice, I'd go with the atropine. But with that said, you do have to think about the possible side effects of the atropine based on your age of the patient and potential side effects as well. You know, it's really for ketamine, because that's your hypersalivation, right? Ketamine causes increased salivation, increased secretions. But again, if you're using the ketamine, I guess you can consider the atropine. It's not something that I use in my practice.
So while we're on the topic of ketamine, since you're a proponent of ketamine, have you ever run into laryngospasm?
I haven't, surprisingly.
Okay.
So I do go, usually you'll see those laryngospasms within the first minute of administration. I know on the adult side, many people say you can just slam that and they'll be fine, no issues. On the pediatric side, however, there will be issues. They'll stop breathing on you. And usually it's on the very first minute of administration, you'll either end up with laryngospasms or they'll just become apneic. So you have to be very careful with that. That's why that is one thing I do harp on, is please administer very slowly that ketamine. And, you know, usually I'll go with 1 to 2 milligrams per kilo, depending on the age of the child. Usually less than about 3 and below, I'll go with about 1.5 to 2, depending on. And for the older ones, I'll bring it down to 1, just because of the metabolism, and they will chomp through that. So that said, with the ketamine, I am definitely careful, but laryngospasms, I have not had any. I've had some desaturations here and there, and just popping on the oxygen is more than enough with the non-rebreather.
What would be your approach should you run into laryngospasm?
So we already have the oxygen on, so we're okay there. Usually the jaw thrust helps oftentimes. We've had that. I take it back. I had one, and the jaw thrust worked. I had one of my co-fellows who had a couple. I don't know what happened with him, but he said he just put the bag on and let that oxygen go. And he said he bagged one of them and opened up the laryngospasm stopped because he bagged. So, I mean, opening up the larynx, you know, to stop the spasms. So keep that in mind, especially with the little ones, less than 8 years old, even, well, let's say 3 years and below. They have big tongues compared to the rest of the mouth. So if you jaw thrust, they should be okay. And then 8 years and above, again, remember the head is bigger than the rest of the body. 8 years and below, excuse me. Head bigger than the body. So just reposition and make sure that oftentimes that'll take care of most of everything when it comes to the sedation part. Whenever you have complications, always just go back and try to reposition, and 90% of the time it'll be taken care of that way.
Nice.
So just to reiterate, so the younger the kiddo, the younger the child, actually the higher dose of ketamine. So you do like 2 per, and then once they get a little bit older, since the metabolism goes down a little bit, you go down to like 1, 1.5.
Yeah.
How much time do you push that over?
Okay, so usually within a minute, the first dose. It's usually that first dose, and you know, it's already in the system when you go to the next dose. And you do have to keep in mind, make sure that you don't want to put one dose on top of the next dose. You don't want to stack dosing. So we get impatient sometimes. Within the minute of administration, I always tell them, take a minute to administer your initial dose. That minute should be more than enough for you to avoid any kind of respiratory depression, because it's usually that first minute that we tend to see it, and it's documented well in the literature. After doing the 1 minute, I'll do 30 seconds to push the subsequent doses. 3 and below is usually what I use, just general, depending on the size really too. But I usually go 1.5 to 2, 3 and below, and then I'll switch it to 1 after the 3 years of age. So 4 and above, go with 1 meg per kilo. And then the subsequent doses, I just do half of whatever the initial dose was. And again, you have to recall that it takes 2 to 4 minutes for the initial, for the full effect of your ketamine to start working. And again, you know, we don't know the metabolism. Every person has a little bit of a different metabolism. So to really determine how long it's going to work is very difficult to say, but just a rule of thumb is 30 to 45 minutes for the half-life. Yeah.
Do you have a ladder? In other words, like a stepwise approach to sedation? So you say, this is going to be really a minor procedure. This is going to be, I'll use this agent, and this is going to, I need this patient a lot deeper. We'll go with the ketamine.
So again, is it depending on the situation, right? So is this child in pain, or is he anxious? You know, and what am I trying to achieve? If it's something small where I'm just going to end up putting some, you know, it's a laceration, for example, then, you know, you're just trying to put lead on the child and he's so anxious, he's not cooperating, then for that, I'm going to go to Versed, you know, because Versed is going to calm the child down. And it's also an anterior grade amnestic. Thank you. So because of that, you know, I would go with the Versed for that to calm the child down. Now, if you can talk it through and distract the child, then I might not even use anything except for maybe a little bit of Tylenol or ibuprofen or something. And you do have those nice and docile children that are comfortable with that. So if you can go with that and you measure it, you know, you have to go in there, look at the child, you know, try to establish rapport, not just with the parents, but also with the children. And if they're comfortable and they're allowing you to remove the LET, or you're having a hard time applying the LET, then you already are starting to think ahead. Okay, this kid's going to be pretty anxious, or he's going to fight you. So in that case, you know, I'm already thinking intranasal Versed. Intranasal Versed works much faster than going oral. And then oral, it's usually 40 to 60% less successful than just doing intranasal. So that's why I always go intranasal for me. That said, having to put an IV is difficult on a child that's already stressed out. So that's why for me, my go-to is always intranasal Versed. If you worked with me, you see, oh, just give them intranasal Versed. Once they calm down, then you can establish your IV or so forth. Now, if this is something where the child is just in a lot of pain, then I'll just go with some fentanyl. You do have to keep in mind Versed plus fentanyl is going to give you probably a little bit of a moderate sedation. So do keep that in mind. Depending on the institutions that you work at this institution, I believe it's 10 minutes from one dose to the next, be it fent, and then you can give Versed 10 minutes later, and it's no longer considered a moderate sedation, but do check with the institutions you're working at. At UNM, where I worked, it was 15 minutes. And so then it was no longer considered a moderate sedation. So do keep that in mind. So again, it depends on what you're targeting. Are you trying to hit an analgesic, an anxiolytic? What are you trying to accomplish there? Is it a minor procedure? If it's a minor procedure where I just need to pop maybe a staple or two, I'll go straight with the LET. If they're still fighting me, then I'll do the intranasal Versed, wait 10 minutes because it works really fast. And once they've relaxed, I just go in and staple, because then there's no trauma to anybody else, potential trauma, to include, you know, whomever else is assisting you by holding the patient and so forth. And that's a great opportunity to kind of really evaluate the patient's temperament when you're starting to clean off, you know, just a small procedure. Hey, I'm going to take off the Band-Aid. You know, you can start looking at that patient and evaluating, deciding what your next plan is going to be, you know. Then from there, if the kid is really anxious and is already, you can't even get near the child, I've already, you know, said if it's something that I need the child to be immobile, I'm already getting the documentation ready so that I can get consent forms. So if it's something quick, like it just requires a stitch or two, I'll just go with propofol, you know, because that one's rapid onset, rapid offset, and, you know, you get in there, you push, and then you can put 1 or 2 in there. Because again, it's very difficult. And I've used that when I had a through and through laceration of the tongue, you know, on that one, it was difficult. So I tried the propofol. That was my mistake. It didn't work because it was so rapid. So ketofol, we ended up just advancing to the ketofol, and it worked perfectly.
Okay.
So again, do you need the kid mobile or not, or immobile? And from there you can just advance. So usually I'll go just with Versed, then I'll move on to propofol, is something short. Ketofol, if it's, it's some, like a pilonate assist. And then if it's something a lot longer, that requires muscle relaxation, then I'll go straight to the ketamine. Those, especially ortho will love you if you have complete muscle relaxation, because it makes their job a lot easier. So that's where I go with that stuff.
Nicely laid out.
Mind actually telling us a little bit about the dosing when you do like IN Versed, IN Fent, and then also your propofol dosing you like to use?
Yeah, so I usually go with like the Versed, intranasal Versed. I'll go with, and it depends on where you work again, but I'll go 0.3 to 0.5 for intranasal Versed. Some people have documented 0.2 to 0.3. But again, depending on the literature you look at, I think Harriet Lane also goes up to 0.5 megs per kilo of intranasal Versed. Maxing out at 10 to 15. Again, you need to find out institution you're working at, what's their maximum. Here it's 10 for intranasal. For the Fent, I go 1 to 2 mics per kilo for the intranasal as well. What else? For the propofol, I'll go with 0.5 to 1 meg per kilogram, depending on. I'll go a little bit higher on the younger ones. So I'll go with the 1 meg per kilo propofol for the younger ones, and the older ones I'll go with the 0.5 and kind of titrate depending on. When I go ketofol, I do the 0.5, 0.5, so 1 to 1. Ketamine and propofol for those.
Yeah, I feel like I've seen for the Versed, like the 0.2, it's like a little bit low. I feel like it's often under sedates. And so I'm glad you said like 0.5. So it seems more reasonable.
I think so too. 0.3 to 0.5. Unfortunately, here they max out at 10. Again, ask your institution, because at other places it's 15. So, and I feel like it's justifiable. If the kid's older, he can take it. He or she, and it's much more humane than having them stressing out and fighting you and so forth. And it's safe for the staff as well, because you have to consider the staff that's assisting you, because you don't want any potential injuries on top of that.
And what are common pitfalls you see residents falling into when they're performing sedations with a little more autonomy, and where would you say they could improve?
I think the biggest one is the stacking. So we need to remember the properties, and also consider the patients you're taking care of. For example, when you're using ketamine's great, right? Because it's as far as cardio, it's not really going to affect much. But you have to keep in mind that if you have a child who is a chronic child who maybe has pulmonary hypertension, that's why I always ask, and I know it annoys people, but I always ask, was the kid preterm? Because if the kid was preterm, then, atropine, you better be careful with your atropine, because as far as bradying out and vasovagal, you will have that. So you need to consider your atropine at that point. But on top of that too, whenever you have preterm babies, more than likely they're going to have more airway strictures, because they were more than likely going to be intubated. So that said, ketamine's great, right? Because it dilates, it's a bronchodilator and so forth. So it actually assists with that. Keep in mind, of course, that you're going to have all that hypersalivation and so forth. So you kind of want to weigh that out. But then again, you want to take a look at, your other resources. So, I mean, some people even use etomidate, which they used to use quite a bit for CT scans and so forth back in the day, which they're no longer doing. But again, you want to try to consider which patients you're taking care of to decide what you want to use for that. Again, if there's a child, going back to the ketamine, if you have a child who was an extreme preterm baby, they're more than likely going to have pulmonary hypertension. So do keep in mind, ask the past medical history, ask what the medications are, because, you're going to get yourself in trouble if you end up with the ketamine on a kid who already has severe pulmonary hypertension and so forth. So do keep that in mind, and try to pair up the particular type of medication with your patient. So Oftentimes I feel like we take some shortcuts. Any past medical history? No? Okay, good. And then you just keep going, right? Because it's ED. And we have a lot of patients. But in these kids, I would caution, kind of take a little bit slower, ask specifically, because a lot of our population is so used to just saying, no, 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 no. And then later, oh man, and asking, have they had any prior anesthetics in the past? And if so, have they had any reactions to them? Because again, I think that's something that we need to follow up on, review systems and past medical history. Again, it's not just to waste time, but we do need to know what the past medical history is to kind of determine what kind of medications we're going to administer ahead of time. What else? The stacking is very important, because I've had kids stay in the ED for up to 2-3 hours because they haven't gotten, they got so much ketamine. So again, you have to be patient. Remember that 2 to 4 minutes is onset. Oftentimes within the 2-minute line, you're going to see these kids already responding. I mean, within the minute of administering, we all see, you'll see those little eyes dancing, and it's already started working, right? And so, and I think it takes practice. We just, as soon as a kid starts moaning, we know that's one of the side effects of ketamine. So know the side effects of whatever agents you're going to use, and make sure that you're well prepared. So again, in pediatrics, it's a little bit harder because trying to guess, because again, just metabolism and just the behavior, you need to try to modify. So you're all constantly titrating these medications, but you also have to give it time to start working. And you have to keep that in mind, because otherwise, when you have a full waiting room and you're just trying to rush through something, you're going to have a fuller waiting room, because now you're waiting 2-3 hours for the kid to come back. So, you need to determine when you're going to discharge the child. Well, you need to make sure that the child's vitals are stable. Number one, they're awake, they're able to ambulate, and they're able to tolerate PO. If all of that is okay, and then they have a responsible adult or caretaker with them, and that person understands the discharge instructions, even if the patient is still a little bit groggy, but is able to walk, or at least has truncal support where you can put them into the wheelchair and then wheel them out into the vehicle, that's fine. But again, you need someone who's responsible and who understands what the return precautions are. So again, I think the biggest things that I've seen is, one, making sure that you understand whatever agent you're going to use in and out, and potential side effects, and being able to rescue that child. Because again, with these kids, you shoot for moderate sedation, you end up with deep sedation. So you better darn well know how to rescue a child from deep sedation. So whatever the sedation is, go a step further, because that's what happens with our kids. Sometimes we overdo it, and it's not our fault. It's just metabolism again, and little bodies, and just it's difficult. It's not as easy with the older patients, I would say. And then again, the stacking, you have to be patient, because you have ortho staring at you like, are you ready? Are you ready? You just have to be calm and say, no, I'm not ready. We're going to wait until the patient's ready. The other thing I've noticed is, you ask the nurse, check for yourself, and I've been guilty of it myself, where, hey, is everything ready to go? Yeah, everything's ready, doc. You go in, capnography is not working. Capnography is number one. Like, I will not do anything unless my capnography is ready to go, because that'll tell you minutes, 2, 3, 4, 5 minutes before the kid ends up desatting, that something's wrong. So I always make sure that all the equipment's ready to go, to include suction, because I've had patients where everything's ready, supposedly. Residents like, we're ready, just come on in. Okay, I go in, and suction's not ready. There's no suction, or they don't have a yonker, whatever it is, I've seen that stuff. And then the big thing also is positioning. Like, oftentimes we forget to position our patients, and then they start having that the snoring type of thing, and they're like looking at me. I'm like, well, I'll reposition, guys. So always remember the repositioning before you start doing anything else. Just reposition your kid, and I bet you 90% of the time it's going to fix everything.
Critical historical factors: were they preterm? Were they extremely preterm? We got to watch out for the pulmonary hypertension. I totally would have missed that. I think that is, like you say, we rush through those questions. Have they had reactions to anesthesia in the past? Another critical one. And then patients who are ready for discharge are ambulatory, they're tolerating PO, they're awake, or they have a caretaker that can watch out if anything abnormal happens, and kind of is in the loop with the return precautions.
Right. And vital signs are stabilized because, of course,
Vitals.
whenever you give those medications, they're going to go up, right? So you want those to come down smoothly. Okay. Yeah, okay. Those are your big ones.
And then thorough prep for the sedation. I don't know, a checklist sounds like it's in order, just not to miss any little piece, be it suction, positioning, monitoring, so on.
And I used to use that. And actually, that's a good idea. Maybe we should do that. We had that back at UNM, and I reference that because that's what I'm very comfortable with and familiar with. We always had a checklist. And in that checklist, it included your A, B, and C plans for, any kind of potential airway. So actually, that's a very good plan.
Well, that hits all of my questions. Ryan, jump on in.
Yeah. One point I just want to reiterate that you said, Dr. McBride, I think is awesome, is like we use so much ketamine and we are like in love with it as like an emergency department, and the stacking thing is so real where you give a bunch of ketamine, ortho does their thing for 10 minutes, the kid starts moaning a little bit, and then we slam them with a whole other dose. And then they're out of it for 45 minutes or an hour, which at our institution, it's not a big deal, or like a training center, people are going to sit around for 2 or 3 or 4 or 5 hours anyways. But in a community hospital, you don't want to do that and keep them around. And we aren't using a ton of propofol, I'll tell you the truth. And that kind of seems like that would be a good time. I've done it like once where we do, ketofol at the beginning, and then we try to transition and use a little bit more propofol towards the end of the procedure. It was a little bit more successful, I felt. So I'm going to try to like incorporate that into what I do. But I think it's really good for the residents just to think through like ketamine's awesome, but it's not the only thing we should be using.
Right. The side effects. Remember your side effects on these medications. And again, with ketamine, you'll have the rigidity, you'll have movement with them sometimes and spasms, but that can be a side effect. And even the moaning and screaming, that doesn't necessarily mean they're in pain. So oftentimes what I look at is, I look at where they're at baseline prior to administering my medication. And then within the minute of administration, I'll go ahead and document, just mind check myself and say, okay, this went up to, and you'll see me looking at heart rate because usually that's what goes up faster, right? Because blood pressure is every 3 to 5 minutes. So I'll look at the heart rate. Okay, it jumped up and usually it's about 10 to 15 above baseline usually. And then it sits there because that's that's one of the side effects to your ketamine, right? So I'll look at the heart rate going up and keep it in mind. Okay, so this kid started at 114, now he's at 124 or 130, whatever it is. Okay, when he's starting to have pain again, you'll see that heart rate shooting up, and that's when I know, oh, he's going to need another dose here soon. You just see it slowly climbing up, as opposed to, oh, the kid's starting to moan or move a little bit. That's still not very helpful. And I tend to ask ortho too, how much longer? Are you guys going to push on this, or what's going to happen? Communication is definitely something that's very important, so talk to whomever your specialist is that you're assisting with the sedations, because it's not just ortho. Just check in and see, how long is this? Are we halfway through? Are we done? How much more, I need to give another dose. Do you think I need another dose? And just communicate with them. I think that's another big one, because oftentimes we don't want to bother our specialists, but just communicate and say, hey, I'm thinking of giving another dose. How much longer? Because if the kid can kind of just go through it, because it's only going to be another 2 minutes, it's worth not administering that second dose or third or fourth.
How about emergence reactions? How do you try to prevent those?
So, and that one's hard because usually I always tell parents, keep them happy, because the way they go in is the way they're going to come out. So if they're crying, usually those are the ones that are going to have respiratory issues. I don't know why. I mean, they're just crying so much, and then they just stop crying, and they become apneic. The ones that I've had that have become, or just desaturated, not apneic, but desat. It's just you give them medication and it kind of slows them down, and then they relax, and we end up having to increase the oxygen a little bit more than when they were nice and comfy. So I try not to upset them. I try to keep parents in there until that they're done. They're snowed, they're ready to go. Then I ask parents to step out, and I think that's another issue with the parents stepping out, depending on the type of relationship. And again, you can kind of pick up on it on the kids, right? So some kids are much more comfortable having mom holding their hand, and that's fine with me, because I don't want them crying. If they're going to cry, they're going to come out 10 times as worse as they went in. Okay. And so if they're crying, they're going to come out fighting. And so I try to keep them as calm as possible, keep the room quiet, just do what we need to. If the kid's already antsy, I have parents come out, explain to them what's going to happen, so the kids don't freak out. In those instances, I will give Versed prior to administering the medication, because it does actually help with with the type of side effects we're talking about. So give them just a smidge of Versed to calm them down. And parents will tell you, ask your parents, talk to your parents. Parents know, we see them for 15 to 30 minutes. These kids, parents, ask them, hey, is your kid antsy or not? Was he going to cooperate? I don't know, or yeah, he's an anxious little guy. Oh, you know what? How about let's do some an anxiolytic? This is Versed. Have you ever had Versed? No? Well, let me explain to you what Versed is. Oh, I like that. So now they're calm. Parents are calm. Anxiety level's gone.
Are you, asking them to come to leave for every sedation or be part of? No. Okay.
No, it depends. Again,
I try to
talking
about this.
Yeah, and it takes, establishing rapport with both the parents and the children, right? So if you notice that, the child is much calmer when mom's by their side or daddy, then leave them there, again, kind of get an idea to explain to the parents so you have to explain to the child and the parents, and again, I think this takes practice, you trying to estimate how the child is going to respond, and then the parents. So if you know that this kid is antsy, you ask parents to step out, you explain to them what the situation is, what the procedure is, and then ask, how would you like for me to proceed? Do you want to explain to them and I'll just fill in? Or would you like for me to explain to them what the procedure is? Or, you know what, don't tell them anything. They're 5, they're not going to understand. Okay, so now we've included them. And that also kind of works with your press gaining scores on top of that, And so you're cooperating with parents, child, and yourself. So it takes more time than, with the adults sometimes. That said, you go in, you explain, you do whatever it is, and parents will tell you, what, my baby is really anxious and he doesn't, and you see as soon as the baby runs out, when mom walks out or dad, the kids start screaming and crying, then you probably want the parent there. Keep in mind, you've explained to the parent what you're going to do. If it's, because you always have those parents who are like, yeah, I can stand this, I can watch, and then they end up passing out. Or, they're about to, they have these pre-syncopal episodes. So, hey, I'm going to open this up. I want you to look. If you start feeling queasy, please be honest with me, because I don't need a second patient. I usually tend to joke with them, but it's the truth, Yeah. And so, you know what? I can't stand blood. Okay, then. So I'll just have you sit alongside them. I don't want you looking at the baby. Just hold their hand and talk to them, and so that'll calm them down. They don't need to leave, and those are for, be it INDs, lacerations, whatever it is. Now, when it comes to ortho stuff, it's unnecessary for them to really be there, because the child is no longer going to see them there. And, there's already too many people in those tiny rooms. And on top of that, you have all this big equipment in there. Yeah. And then again, you're going to have to ask them to step out, and then, potential for radiation exposure and so forth. So I do actually ask that they step out when it comes to that type of situation.
Nice. Well, this is exactly why we do this, because pediatric patients pose a specific set of problems that we're training to learn to deal with and try to manage. So I really appreciate all those insights. Anything else you want to add in terms of managing the pediatric patient and sedating them?
The other thing is control the pain, because if you can control the pain, you control the anxiety level, both for the patient and the family member. Okay. And it makes that a much, much smoother ride for everybody, including nursing staff and so forth. So keep them happy. So that's another pitfall. We tend to ignore the pain oftentimes, and we just, I say, oh, okay, they took care of it in triage. Well, not oftentimes. So make sure that you go in and get your pain score. And we have those on the board. We have the little smiley faces, sad faces, and so forth. So find out and control that pain. What I do is I'll give morphine to some of my kids. I'll give the Fent because it's 10 times stronger than your morphine, but it's also rapid onset. Unfortunately, it's rapid offset, but I will give the Fent if we haven't established an IV just yet. And then afterwards, if they're still they're starting to complain of pain, I'll give them morphine. And then after the morphine, I'll administer whatever medication I need for, you know, if it's a fracture or whatnot, then I'll go ahead and administer the ketamine and get that taken care of. Because again, morphine will sit there for a while and help with the control, with the pain aspect of it, as does ketamine. That's, I mean, for me, it's my go-to most of the time, ketamine, because it has so many wonderful properties and less side effects. But at the same time, you do want to consider you're a shorter acting, like your propofol.
That's all the questions I have. Ryan, anything else from your standpoint?
No, that was awesome, Dr. McBride. We appreciate it so much.
Totally. Thanks, guys. You guys take care.
All right, great.
Good night.
Have a good night.
You too. All right. Bye.